This is the shape of the generator, and this is the structure of the generator. It should have here, as you see, a molybdenum generator, molybdenum column. This the radioactive material, we call it the parent, and this molybdenum, due to its virtue of radioactive nuclear decay, it will goes down to the technetium 99M. So this we call it the parent, and this is the daughter. And this we are using mostly in nuclear medicine. Okay. So during this is we call here we putting a vial with normal saline, and here a vacuum. So the normal saline will goes through this column. It will wash out or milk. We call it milking the technetium material, and this material will goes here in the vacuum vial. Then we can use this one and for our nuclear medicine studies. So I think it's clear. So the most commonly used radionuclides, what they are unstable atoms. They should, because unstable, it means they should undergo decay, resulting in emission of different type of radiation, which used in nuclear medicine. The most commonly used is the gamma rays. There is also some X-rays, but mostly we are relying on gamma rays. So also we are using in nuclear medicine, sorry for this one. We're using beta rays that used for therapy. The gamma rays have the capability to emanate from the body and to reach the detector because it having longest X-ray, longest radiation. But the beta, it will stay near to the place where it's depicted. So let's move highlights. The prevalence of disease of the thyroid gland is high, although not always diagnosed clinically. The diversity of thyroid disease is very wide in population. The metabolic rate in the body is directly influenced by thyroid hormones. You study that one, the T3, T4 hormone. Yeah. And the correct management depends on accurate diagnosis, of course, followed by appropriate treatment and follow-up. So here, nuclear medicine always played a leading role in all aspects of thyroid disease management. In the next slides, I will show you examples and scenario to see the importance of nuclear medicine in treating thyroid disease. As you know, this is the usual location of the thyroid. It's in the anterior neck. Yeah, you can see two lobes, right, left, both sides of the trachea in the midline, and it's usually situating in the anterior neck, superior to the suprasternal notch. But you can encounter many normal variants and shapes of the thyroid gland. Of course, you study that there is a hormonal feedback control for all these T3, T4, the function of the thyroid. It's related to the hypothalamus and it's related to the pituitary gland. So depending on the situation and the thyroid, there will be either increase or decrease or increase of the production of the TSH. TSH is thyroid stimulation hormone. And of course, there is feedback for the TRH. TRH is the thyroid releasing hormone. Okay. So these hormonal scenarios happen in the body depending on the situation of the thyroid. So we call it thyroid pituitary hypothalamus feedback. Okay. If there is excess of the thyroid, so it will give order that the pituitary will reduce the release of the TSH, or vice versa. In hypothyroidism, the vice versa situation happening. Okay, so what's the common thyroid disorders you found in population? Firstly, you will encounter the goiter, thyroid nodules, hyperthyroidism, hypothyroidism, Graves' disease, thyroiditis, Hashimoto's disease, and thyroid cancer. I will show you some examples for this situation, the most commonly encountered. So let's say, what's the advantage of nuclear medicine, or what we call it scintigraphy? The advantage, as I mentioned in my previous lecture about the endocrine, it's a functional imaging. It's not showing only anatomy, it's showing the real uh, functional status of the thyroid or the organ. So you will get functional information in addition to anatomical. In nuclear medicine, you can see the whole gland in one image. I will show you. And you have the ability to place marker of the anatomical markers. It means to put where is the suprastellar notch, the chin, or if there is a scar after surgery, you can place these anatomical markers. And it gives you an objective data. Why? Because it's functional imaging. Yes. If you goes to know what the disadvantages of the nuclear medicine, the first thing is the fear of something nuclear. And people thinking that nuclear related to maybe weapons or something like, or bombs. So there is some fear when you hear the word nuclear. But why they call it nuclear? Because the gamma rays is coming from the nucleus. It's not coming from the out shell electrons. And of course, disadvantage cost, it's costly because you need this radioactive material, which should be brought from nuclear reactor. And of course, the equipment, the gamma camera, very expensive. And also the availability, because you need a nuclear reactor to produce the molybdenum, which I show you, the generator. And there is some contraindication. We call it not absolute, relative in pregnancy, and if the patient female and lactating. Okay, so for technetium, these are what you call relative, but for iodine, it's absolute. You cannot give. Why? Because the absolute can stay longer time, especially in therapy. Yeah, if you compare this modality to the sonography, you will find many advantages. Advantages is popular acceptance, it's cheaper, available everywhere, and it's radiation free because sonography. But there is disadvantages of ultrasound compared to nuclear medicine. It's showing only most anatomical information, and it's highly operator dependent. Remember this one, because depend from person to person. It will not give you an objective data. It will give you subjective data. Okay, so let's go to what's the indication in nuclear medicine for thyroid disease. Evaluation and determination of the functional status of a palpable nodule. Patient came to you and he telling you that he have a mass on his anterior neck and you feel a nodule. So to know what kind of this nodule, hot or cold or multinodular goiter. So nuclear medicine can differentiate, and I will show you scenarios about this one. Also, to confirm the retrosternal extension of a thyroid gland, we call it retrosternal goiter. And you can do also nuclear medicine, a baseline before thyroid surgery. Why this important? Because surgeon thinking that they remove the whole thyroid in case of cancer. But actually, it's happening that maybe sometimes big part of the thyroid left behind. The surgeon did not remove everything. So when you have a baseline before surgery and you have a thyroid scan after surgery, you can compare. So also you need to do an baseline before thyroid therapy with radioactive iodine and for dose calculation. Also evaluation for ectopic thyroid tissue, if there is ectopic in case of metastatic thyroid cancer, evaluation of thyroid toxicosis hyperthyroidism, evaluation of hypothyroidism, and evaluation of thyroiditis. Okay, let's talk for the most commonly encountered the nodules, which is popular. So 50% of autoprized glands contain nodules. The ratio between male and female is more common in female, 6:1, and it's age-related incidence of nodularity. Most frequent indication for thyroid scanning, 25% you will find solitary, and 75% of cases you will find multiple nodules. This is very important. Between 5 and 15% of all clinically detectable solitary hypofunctioning, we call it cold nodule, will be found to be malignant on appropriate evaluation. Okay, so it is important to make investigation for any solitary cold nodule, biopsy, fine needle aspiration. Okay, so classification of nodule mainly is classified between cold and hot. Cold, it means non-functioning nodule. Hot, it means looks like hyperfunctioning. So between 5 and 40% of cold nodule, it will turn out to be malignant, thyroid carcinoma. In hot nodules, less than 1% to be malignant. And we have another entities like discordant nodule, yeah, which is 2 to 3. I will explain what the meaning of this discordant nodule. And we have a hot nodules. Yes. So I will show you examples of what I am talking about. Let's first start with how looks the normal thyroid imaging. You do a thyroid scan and you will see the right, left lobe, here submandibular salivary gland, parotid gland, mouth activity in the gland. Because the tracer, the technetium, which I inform you, 99M technetium, is excreted by salivary glands. So mouth, parotid, submandibular, and here the thyroid. Okay. Now I will start with the cold nodule. This is a case of solitary large cold nodule. Why we call it cold? Because it is hypofunctioning compared to the rest of the thyroid gland. And you see it is big, large cold nodule occupying part of the thyroid, the right thyroid lobe. And here the suprasternal notch. So the thyroid is normal location. It's not going below the SSN or inferior to the suprasternal notch region. Okay, so I will show you some scenarios about what we are encountering in our practice, and maybe in the future you need to know these scenarios to know what to do with such patient. 62 years old male patient referred with multinodular goiter to rule out cold nodule. Okay. Why multinodular? Either by palpation or ultrasound showing multinodular goiter. This is very important. Sometimes ultrasound will show you nodules so small, like less 1 centimeter in diameter. Let's say 4, 5, 6, 7 millimeters. These nodules usually will not be detected by nuclear medicine. The importance is a nodules which is more than 1 centimeter. It having clinical importance. Less than that, it's clinically insignificant. So we did for this patient a thyroid scan, and you see here, this is the right lobe, and here is the left. So we find a large, big, cold nodule occupying almost the whole left lobe. So in this case, you will not deal it as a just only simple multinodular goiter. You will deal as there is a dominant large cold nodule which need biopsy or fine needle aspiration. So this is a multinodular as it was referred by ultrasound, but there is a large cold nodule left lobe reaching the SSM. So biopsy is must. Why? To exclude malignancy. Okay, and of course thyroid function test to document the functional status of the thyroid gland, either it is above or below the normal limits. Okay, this is another example of multinodular. Here you can see different cold areas, here one, here one, here one. So in such cases, when you have such picture, it's less than 5% to harbor malignancy. So in this case, no need to do any surgery, unless if there is some signs of what you call compression syndrome. It means to make you, we call it debulking. If patient cannot breathe or difficulty in eating or gluttification, so maybe just only to remove part of the thyroid that easy for the patient, or because of the cosmetic, it's big on the anterior neck. But regarding malignancy, these multinodular having less percentage of being a cancer. Okay, so sometimes this multinodular coming without any hyper-functioning status or situation, but in sometimes it become a malignant, a toxic. It means increased hormone thyroid, like in this case. This is a toxic multinodular. You can see some areas with high activity. It's trapping too much tracer in this area, this area, this area. And also we can make a, what you call it, a percent uptake calculation. So in this case, the uptake is 4.5. The normal range is up to 4 or 3.75. So in this case, we have toxic multinodular goiter. You need to treat. So either you will treat by giving medication or treating by doing surgery, removing the majority of this toxic, or you can treat by using radioactive material. Yes. So what we can say about this toxic multinodular goiter? So associated with hyperthyroidism, it can. So you will have elevated thyroid hormones, especially free T3, and you will have suppressed TSH. If you remember the feedback between the pituitary and the thyroid, when there is high, then high excretion of thyroid hormone, you will have TSH suppressed. Yeah, because feedback. Yeah, the thyroid stimulation hormone will be suppressed. If you, I showed this slide in the beginning. Okay. So another scenario, 45 years old male referred with goiter, pain in thyroid, and hyperthyroidism. It means high thyroid hormones in the blood test for this patient. So we did for this gentleman an image, and look what you get. This is the suprasternal notch. Here, the submandibular salivary gland. So you expected to see the thyroid in this, but you can see barely, you could see some activity of the thyroid. Yeah. So it is faintly visualized thyroid gland. And when we did the uptake, it comes very low. You see, 0.18. The minimum, the lower limits of normal is 0.5. So this actually in the picture functional imaging showing that the gland is not trapping the tracer. It means it's not working. Although biochemically T3 and T4 are high. Why this happening? If you start to treat the patient as a hyperthyroid and giving him antithyroid drug, it means you are harming the patient. Why? Because you did not reach to the actual diagnosis. The actual diagnosis, why this picture, why we see, because the patient not having a real hyperthyroidism. Yeah, this patient having a subacute thyroiditis, viral, you call it. Yeah. So because you cannot see the gland and the uptake is very low, so this diagnosis change the, uh, the plan of therapy. And usually we are advising to repeat the scan after 8 weeks. Why? Because subacute thyroiditis is a self-limited disease. So if the patient come to you after, let's say, 6 to 8 weeks, you will see the normal thyroid because the thyroid will recover from this thyroiditis. It is self-limited disease. This is one very important example how nuclear medicine can change the diagnosis and how can change the therapy, okay, the approach to treat that patient. Okay, another scenario, 31 years old, sorry, 31 years old female patient referred with thyroid toxicosis, high free T4 and low TSH. No evident symptoms of hyperthyroid. Hyperthyroidism, I mean, there is no exophthalm, there is no tremor, there is no. So we did an image for this patient. Again, you see similar picture, faintly visualized thyroid gland. It means the gland did not trap the activity. So it's the same story like in the first scenario. And also the uptake, you see, the uptake is 0.28. It is less than 0.5%. So is again this patient having thyroiditis instead of thinking that the patient is hyperthyroid. So the conclusion that faintly visualized consistent with thyroiditis, such as subacute 1. Okay. Now I will move to another intensity, which we already talk about the nodule, the multinodular goiter, the toxic multinodular goiter, and the nodules, solitary, cold. Yeah. So let's move to the Graves' disease. What's the Graves' disease? As you know, it's an autoimmune disorder caused by thyroid stimulating immunoglobulin, TSI, against the TSH receptor, against the thyroid stimulating hormone in the pituitary on the cell surface of the thyroid follicle. Thyroid function, sorry, against the receptor on the thyroid follicles. Okay. So serum thyroid hormone levels are elevated. TSH level is suppressed. Yes. And the uptake, when we're doing radioactive iodine, this radioactive iodine uptake is usually elevated at 24 hours. Also, it will be elevated on the technetium generator. So patient who having markedly increased thyroid hormone synthesis and turnover, they call it rapid iodine turnover. The 24-hour uptake is normal, but the 4 or 6 hours radioactive measurement is elevated. This is because of the high turnover inside the gland. Yeah. So when we can measure the percentage uptake by using either technetium or iodine. Here I am talking about the iodine, the 24 hours or the 4-6 hours. So the Graves' disease patient coming with goiter, the gland is enlarged, diffusely enlarged, and the patient may have the symptoms like the exophthalm, like in this picture. Yeah. So sorry for these technical things. So I will give you one scenario about one, this Graves' disease, 57 years old female, referred for radioactive iodine therapy for her hyperthyroidism. She is on neomercazole. Neomercazole is a tablet anti-thyroid drug. We need to stop it 1 week in preparing for this study before doing. After 1 week of thyroxine or of neomercazole, we do the image, and you can see now the gland. Now, if you look here, the suprasternal notch, you expected to see, sorry, yeah, the you expected to see the, I mean the salivary glands, the submandibular, the parotid. You cannot see it. Why? Because the thyroid gland is hyperactive. It traps all the radio pharmaceutical or the technetium from the bloodstream because it's very active. In normal cases, I show you, you will see something goes to the thyroid and some tracer will be excreted by salivary gland. In this case, there is high gland to background ratio. Yes. And of course, we're measuring the uptake for this patient. Yeah. You see the uptake, percentage uptake is 13, almost 14. And I told you the maximum up to 4 or 3.75. So this is actual, the thyroid is hyperactive compared to the thyroiditis. In thyroiditis, you remember also you have high T3 and suppressed TSH, yeah? Thinking that this patient is hyperthyroid or Graves. But actually, in that cases, you cannot see the thyroid and the uptake low. Here is a real hyperthyroidism. Yeah, this is the importance of nuclear medicine. So this is toxic diffuse goiter, and this patient is candidate to receive radioactive iodine treatment instead of doing surgery. Before they were doing surgery of the gland, they may do subtotal or subtotal thyroidectomy to eliminate the hyperthyroidism. But better to do in such cases radioactive iodine. Why? This radioactive iodine, it goes to the thyroid and it's emitting beta radiation. The beta radiation will destroy the follicles of the thyroid, and without doing surgery and without doing a scar for the patient and the risk of surgery. Yeah. Okay, this is, I will show another situation of toxic goiter. Again, see the picture. You cannot see the salivary gland because there is high uptake, 25%. It means about how many? 3, 4, 6, 7 times above the normal. So these two examples of Graves' disease. I will go to another entity. You have a patient, 31 years old female, referred with big thyroid nodule in the right lobe. And this is the size given by ultrasound. And biochemical, TSH, you see, suppressed. So expected to see a toxic nodule. Why? Because there is high thyroid function, T3, T4, expected to have a low TSH. So we did an image for this patient, and here the thyroid bed, the area of the thyroid bed, the suprasternal notch. Here you cannot see again the salivary gland. Why? Because the whole activity is taken by this nodule. And this arrowhead is the, when you palpate during the image, you can put anatomical landmark. So everything's taken up by this functioning area, and you cannot see the rest of the gland. What we're doing, we are sometimes covering this area by a lid, yeah, in order to see the part of the left thyroid lobe, and now you can see what the salivary glands, because we cover this one. It means we obstruct the gamma rays to go to gamma camera from this area. So we give a chance for other gamma rays to be reach the to depicted on the gamma camera. Here, you see, it's taking everything. It's on the right side, and here, because this is the the midline. Okay. No, and here, of course, the percentage uptake is 6%, above normal, above upper limits of normal. Okay, so this is the conclusion in this case. We call it toxic autonomous nodule or adenoma of right lobe with complete suppression of the extranodular thyroid tissue. As you see, there is nothing seen. It is suppressed. Why? Because this is autonomous and toxic. So for this case, it's very beautiful to give radioactive iodine therapy. What will happen in this case? The radioactive iodine will destroy many follicles of this toxic nodule, and then while the rest of the gland will not be affected. Why? Because this hot nodule will trap all radioactive material, and it will treat this one, and it will not affect the rest. After that, then you can see, if you do the image, you will see the rest of the thyroid tissue. Yeah. Another scenario, 27 years old female referred with left lobe thyroid nodule to rule out if it is cold or not cold. The patient is on thyroxine. Why? Maybe because she is hypo. And we have to stop this thyroxine for 4 weeks in preparing for this study. Why? Because if the patient on thyroxine, it will block the thyroid from trapping the tracer from the bloodstream. So we did the scan for this patient, and we found here, as you compare this area compared to the rest, it is hyperfunctioning, and this is a nodule, which was mentioned that there is a nodule, okay, with the left lobe. So this is the nodule we palpate, and we found it's hyperfunctioning. Now, this study done by 99M technetium material, in order to make sure that this nodule is truly hot, we need to repeat it with radioactive iodine. Why? Because technetium only trapped, while the iodine tracer is organified inside the thyroid. So we repeat this one. So we call it solitary small hot nodule in upper left thyroid lobe. So why we're repeating? In order to clarify the true hotness. It means the organification function of this nodule, not only trapping. And we did second study using radioactive iodine, not technetium, and we image after 4 hours and after 18 hours. This really is a hot nodule. So nothing to worry about this hot nodule. Why? Because less than 1% chance to have malignancy, not like the cold nodule. This is a very important difference, and remember it. Okay. So this is the conclusion. Comparison with previous thyroid scan, I mean the technetium done earlier. The present one shows also hot nodule, upper pole left thyroid. It means this concordant nodule. It means hot in technetium and hot in iodine tracer. There will be entity, as I mentioned, discordant nodule when it is hot by technetium and cold by iodine. So this nodule to be evaluated in light of clinical data and follow-up monitoring. No need to do biopsy. Okay? Yeah. Now I will show you the other scenario where there is a discordant nodule. This is concordant because hot in both cases. This is a case of a discordant nodule. Yeah. You see, this is discordant nodule. Why? Because it is hot in technetium, but what? Cold in iodine. So this nodules should be treated as a cold, and it should have fine needle aspiration cytology or biopsy because it can be a malignant one. Okay? This is a discordant nodule, we call it. Oh, sorry. Something went wrong. Excuse me. I will be back to my last. Yes. Yeah. Okay. Now to going another scenario. 25 years old male patient referred with post-thyroidectomy. Due to what? Due to papillary CA thyroid. We did a scan for this patient. As I told you, that better to have a baseline study, but in this case, we don't have baseline study. Okay, this is what we see, functioning thyroid tissue, yeah? But we don't know this is from right or left or this local invasion metastasis. And this is the landmark we can put. This is where is the surgery scar, okay? So the doctor referred this patient in order to give radioactive iodine ablation, yes, to remove all thyroid tissue. And we did also by technetium uptake, it is 0.5, the lower limits of normal. In this case, it's better to do second surgery to remove more and more thyroid tissue before going to radioactive iodine therapy. Why? Because with radioactive iodine, if big amount, you cannot ablate it by radioactive iodine. So need second surgery. So two areas of functioning thyroid tissue in anterior neck representing thyroid remnant or local invasion. So no baseline available. We cannot tell it is local or it is remnant. So better to go to second surgery before iodine ablation. Now, scenario, 36 years female had swelling in anterior neck with pressure syndrome, large cold nodule, right lobe, fine needle, benign lesion. 2 years later, surgery was done and it turned out to be a papillary CA thyroid. So you see, it was fine needle. It can give false negative, yeah, as in this case. But it's actually, it is a papillary when they did biopsy surgery. So this patient underwent second surgery, completion thyroidectomy, and referred for radioactive iodine ablation. So we did for this patient, yeah, there was this called the jewel, okay, and now this before surgery and this after surgery. This is nothing, complete, total thyroidectomy, okay. The uptake is almost zero, 0.09, complete thyroidectomy. Status of posttotal thyroidectomy. This patient will go to do radioactive iodine ablation. Somebody will ask why, if it is total thyroidectomy, to give the iodine ablation. Why? Because still there is some few cells of thyroid in the thyroid bed, and you need to destroy these cells for the future follow-up. For the future follow-up. Let's say about this This is the normal location of the thyroid, and here where is the retrosternal thyroid you can find. This is one example. I'll show you an image of retrosternal. Here you see the suprasternal notch. So part of the thyroid is in the thyroid bed, but big part is retrosternally. This, of course, if you need for removal, surgeon should know that the thyroid is extending down. Okay, this an example of retrosternal goiter. I will go to another example about ectopic thyroid. It's you can in children you find it like in this case 6 years old here referred with incidental finding of mass at the base of the tongue. So the doctor raised the question: could be this a lingual thyroid gland? It means the gland is located ectopical and at the base of the skull. Why? Because if he removes this mass without knowing, so this child will be for the whole life without thyroid, and he need a whole life replacement. So we did a scan for this child, and look what we found. This is the thyroid bed, nothing here, yeah? But, and here, you remember submandibular salivary and parotid. And we found here an area. What is this? It is not related to the mouth, the activity in the mouth. No. So, sorry. Okay. So it's not related to the. We did this anterior view. We did a lateral view, and we saw this is the mouth, and here the base of the tongue, and this is the active area. You see it clearly, this round shape. So in this case, this is the only functioning thyroid tissue in this child, nothing in the thyroid bed. So this is an example of what an ectopic thyroid, and in children. Usually these children coming with hypothyroidism because it is a small, it's not producing enough thyroid hormone. And this is the picture which you could see it. Yeah. Here you see the thyroid where it is at the base of the tongue in the mouth. Okay. So good that they did not remove this mass to see what is this mass. Better, good that they send the patient to do the scan to know that this is the thyroid. So this thyroid will continue to function. But of course, if it's not producing enough hormone, this baby or child will need a supplement, thyroid hormones. Now, this one of ectopic thyroid tissue, as I mentioned, yeah? Okay. Now we'll go to scenario of a patient already having thyroidectomy and why to come back for nuclear medicine to see if there is recurrence or if metastasis. 42 years old patient, known case of post-total thyroidectomy due to CA, and also he received iodine ablation. The iodine ablation we're using is 131 iodation, we call it, yeah, due to papillary thyroid, and done more than 10 months ago. Now he is off thyroxine, as I told you, in order to see the image. And this is the image of this patient. So this is a whole body. We are using iodine 123 and to see if there is any thyroid tissue. This is normal. The excretion of the iodine or the uptake of the iodine by salivary gland. Also, it is normal if it is on the stomach, bowels, and by kidneys, excreted by kidneys. So nothing abnormal uptake in the whole body. It means negative. It means the patient is safe, there is no recurrence, and there is no metastasis. This is the image of the anterior nook of the patient. You see, this is the scar marker, the surgery scar marker, and nothing in the thyroid bed. Okay, so it is a negative whole body scan. This patient will be back on his thyroxine suppressive treatment and will live quiet and free. Thank you for listening, and if you have any question, I am ready to answer. If there is no question, can we leave the presentation?
Yes, doctor. Thank you.
Thank you very much. Thank you. Have a nice day. Bye bye.
You too, doctor. Thank you so much.
Thank you.